My name is Dr. Amir Ahmadi, and I am the Director of Inpatient Cardiology at Mount Sinai Morningside. Currently, majority of cardiologists around the world are thinking about risk factors and symptoms as gateway to the whole prevention realm, that usually people go to cardiologists if they either have symptoms or risk factor. Problem with them as gatekeeper is that they're not the most reliable. We've recently shown in a study done at Sinai that of 300 patients that came with heart attack to our CCU at Sinai, if we had evaluated them 2 days prior to their heart attack in our clinic with looking at risk factors and or presence or absence of symptoms, we would have missed about half of those individuals, meaning that many of the times the heart attack happens in a person that up until the moment of heart attack is not symptomatic, does not have any chest pain, and the heart attack could be the very first symptomatic presentation, and in patients that we as cardiologists think that they are low or borderline risk. So the paradigm shift that I'm talking about is that we are going from the risk factor symptom point of view or them as a gatekeeper to back to the drawing board and think about the pathophysiology, the actual reason that the heart attack happens. And the actual reason that the heart attack happens starts with a plaque. It starts with the atherosclerotic plaque that goes through progression, and it causes either a rupture or erosion. Now, identifying that plaque or knowing about atherosclerosis is a wonderful tool that we can have, and we currently do have, but we are not really using it in a large scale yet. But soon enough, we can do that to identify patients that are at high risk and personalize the treatment to stop the progression or start regression of such plaque in order to prevent heart attack. Very good question. So this is something that I think many patients are confused about, and occasionally some physicians. So most of us judge our cardiovascular health based on our cardiovascular fitness. So if I can exercise, if I can play half an hour of tennis or go as many as laps as I want in a pool, or do any type of an activity without getting shortness of breath or chest pain, I feel that I'm healthy. But truly, that's indication of cardiovascular fitness. The difference is you could be completely cardiovascularly fit, but from coronary artery disease standpoint, you could have plaques, atherosclerosis in the vessels of the heart. And that makes me, if I had that, that makes me prone to have heart attack. That makes me prone to have cardiovascular problems. On the other hand, I could be cardiovascularly unfit. If I wanted to exercise, if I wanted to play tennis or go to the swimming pool or whatnot, I could be huffing and puffing because I'm not fit, but my vessels are completely healthy and they don't have any plaque. In the second case, even though I'm not cardiovascularly fit, my vessels are healthier than in the first case. And therefore, we need to be able to distinguish between these two scenarios, both as physicians as patients, and try to look at both fitness and improve that all the time, and cardiovascular health, and evaluate that independent of the level of fitness. Atherosclerosis is a basis of heart disease and the essential element for heart attack. What happens prior to the day of heart attack, probably years prior to that, there is a deposits of fat molecule, LDL molecule, between the two layers of the wall of the artery, the intima and media. And that can grow. And it can grow in a way that it becomes unstable, and eventually the thin layer on top, intima, can actually rupture. The body thinks that it needs to save itself from a problem, similar to when I have a cut in my finger or a cut in my hand, and it will develop a clot. So it will develop a clot around that area of a plaque rupture, and that clot occludes the entire vessel, leading to a heart attack. So going back to your question, atherosclerosis is the basis in which, when it progresses, it makes a plaque prone to rupture and it can cause a heart attack. Without atherosclerosis, we cannot have a type 1 heart attack, which is the most common type of heart attack. Very, very good question. So plaque progression, the way that I think about it, is a necessary step between that early atherosclerosis and a heart attack. Many people think about it as the amount of atherosclerosis in the vessel gets bigger and bigger. It is partly true, but it's not always about more degree of luminal stenosis, meaning that it's not about your plaque going from 40% to 60% to 70%. Partly it's that, partly is change of morphology of the plaque and getting to the shape of a plaque that is more prone to rupture and to causing a heart attack. That progression is necessary to take the very early parts of atherosclerosis to a plaque that is prone to cause heart attack. Now, we can identify that. We can identify the plaque, and we can identify the progression through serial imaging. But more importantly, we can modify it, and we can halt it. How do we halt it? The plaque itself is dependent on the molecules of cholesterol, and it's probably dependent on the amount of inflammation. So by detecting it early, significantly in a personalized manner, in an aggressive manner, reducing the amount of cholesterol molecule in the body and in the blood, and decreasing the inflammation, we can stop progression. I think there are multiple things that we have to do at the same time. One is to promote healthier lifestyle overall in the population, to promote better diet, to promote better exercise. And therefore, by having a healthier society, we're going to prevent so many heart attacks. But that may be not a completely achievable goal. We're always going to have people with plaque. Currently, what we are doing is that we are trying to guesstimate with our risk scoring system, which work well at the societal level, but not at an individual level. If we start thinking about screening process in a costly and accurate manner at a large societal level, that we detect early atherosclerosis, which is the basis of heart attack, and we stop its progression by doing personalized and precise treatment, I think we're going to be much more successful in stopping heart attack. I think AI will have a positive role because it will allow us to identify various different features in the patients, in patients' biomarker, in patients' plaque, in patients' plaque morphology, and through deep learning and big data, it can actually try to figure out how different combinations behave and gets modified based on lifestyle changes, based on medications and whatnot, and can allow us to have a much better way of personalized and precise medicine. And therefore, if I recommend a treatment to a patient, it will be much more informed based on millions of data points and a similar behaviors that we've seen and learned from in the past.